everyone. And today we cover hypertension overview in pediatrics. You know that it is a big topic, but I will try to make it simple and try to highlight the important things. And we end our lecture by clinical scenarios, and we hope that it will be an interactive session. Our objective, the definition and classification of hypertension, when to measure blood pressure, definition of hypertension, emergency and urgency, by age, when to start treatment, evaluation, and then at the end, we end with 6 clinical scenarios if time allowed. The definition, hypertension is based on cardiovascular morbidity and mortality in adults. And in children, it is based on the normal distribution of blood pressure in healthy children, not based on cardiovascular morbidity and mortality. And hypertension is defined by average systolic blood pressure and diastolic blood pressure that is 95th percentile or more for age, sex, and height on 3 or more occasions. This is the definition of fourth report in 2004. The normal blood pressure is systolic or diastolic blood pressure below the 90th percentile, and the pre-hypertension is from the 90th percentile, but below the 95th percentile, and stage 1 hypertension is systolic or diastolic blood pressure equal to the 95th percentile, but lower than the 99th percentile plus 5. And stage 2 hypertension, it is equal or higher than the 99th percentile plus 5 millimeter. This is the classification for the European Society Hypertension Guideline in 2016. They defined the patient by the age from 0 to 15 and 16 or higher. So the hypertension, as we said, it is more than or equal to the 95th percentile, and stage 2 and stage 1 and stage 2 hypertension, as we said. But in 16 years or older, the hypertension is defined if the blood pressure is 140 over 90 or more. This is the table of the centile chart for the age, height, and sex, according to the height and the age. And this is the update of blood pressure categories and stage according to the American Academy Pediatric Subcommittee. And they define the blood pressure definition from 1 year to less than 13 years or from children 13 years or above. So the normal blood pressure is less than the 90th percentile, elevated blood pressure 90th percentile or more, to less than the 95th percentile, and stage 1 more than the 95th percentile or 95th percentile, less than 95th percentile plus 12 millimeter Deba. So we see here there is no 99th percentile in the update definition. And stage 2 hypertension, it is 95th percentile but plus 12 millimeter or plus 12 millimeter or equal to 95th percentile plus 12 millimeter. For children aged 13 years or more, stage 2 hypertension is the blood pressure 140 over 90 or more. And we see here there is the difference that we didn't find the pre-hypertension. If it is in this category, so it is elevated blood pressure. There is no pre-hypertension in the update guideline. And this is the blood pressure for the children according to the age, according to the American Academy of Pediatric Subcommittee. And we notice that the cutoff of the blood pressure is lower than the previous fourth report of hypertension in 2004. This how to measure the blood pressure. We determining the proper cuff size by the patient arm size. We need that the bladder, the cuff of the bladder, which should be 40% of the circumference of the arm measured at the mid-arm, and the length should be 80 to 100% of the circumference of the arm. So the most important thing is the proper cuff size to measure the blood pressure, because the smaller cuff size will give you high blood pressure. When to measure blood pressure, all children more than 3 years of age should measure the blood pressure in the casualty or at any presentation to the emergency or to the clinic, or less than 3 years of age under special circumstances, we should measure the blood pressure like premature infant, low birth weight, congenital heart disease, recurrent UTI, hematuria or proteinuria, renal or urological disease, systemic disease like neurofibromatosis or systemic lupus erythematosus, solid organ or bone marrow transplantation, and drug which increase blood pressure like corticosteroid, tacrolimus, and cyclosporine. Definition of hypertension emergency and urgency. Hypertensive emergency is severely elevated blood pressure. We mean by severely elevated blood pressure stage 2 hypertension with evidence of target organ damage, and most commonly the CNS, the kidney, the cardiovascular, and the eye involvement. Hypertensive urgency is severely elevated blood pressure with no evidence of end organ damage, but if left untreated, will end by target organ injury. This is the end organ damage for the hypertension. You see here, affect the heart by left ventricular hypertrophy and congestive cardiac failure, the brain by hemorrhage and CVA, retinopathy in the eye, peripheral vascular disease, and affect the kidney by renal disease and proteinuria. As I said, severe hypertension is defined as stage 2 hypertension is usually associated with secondary hypertension, while primary hypertension is associated with mild or stage 1 hypertension. Symptom and signs suggestive of underlying disorder indicate secondary hypertension, so we should search for the cause from history examination and investigation to do the investigation going to the suggestive disease from the history. Primary hypertension is associated with overweight and or positive family history of hypertension. Regarding the etiology by age, less than 14 years, it is mostly secondary, it's 98%, and essential hypertension is very minimal, it's 2%, and more than 14 years, essential is 75%, and the remaining is secondary. Etiology by age, according to the age group, the common cause in newborn, renal artery thrombosis and embolus. We should ask about umbilical artery sterilization during neonatal period, renal vein thrombosis, congenital renal malformation, coarctation of the aorta. So we should measure the foreign blood pressure, renal artery stenosis, and bronchopulmonary dysplasia. In infancy to 6 years, the most common cause is renal parenchymal disease, renal artery stenosis, coarctation, and we should go through the medications that the child taken, the corticosteroid or albuterol, and endocrine causes. From 6 to 10 years, renal parenchymal disease, renal artery stenosis, essential hypertension, and endocrine causes. In adolescents, the most common cause is primary or essential hypertension, especially in our era now that obesity is common and white cause, and so you should measure the blood pressure, and then you can do the automated blood pressure measurement, and renal parenchymal disease and substance abuse like cocaine, amphetamine, and caffeine, and endocrine causes. Also, you can define etiology of hypertension by the system involved secondary to the cause, like renal, glomerulonephritis, reflex nephropathy, obstructive neuropathy, and in cardiovascular, like aortic coarctation, fibromyalgia, Wilms tumors, like malignancy, endocrine Cushing syndrome, and as I said, the drugs. I will not go through all this. Okay, so when to start treatment? You should start treatment in stage 2 hypertension, symptomatic hypertension, secondary hypertension, hypertension with target organ damage, as we said, diabetes type 1 or type 2, resistant hypertension despite non-pharmacological measures. And we mean by non-pharmacological measures like DASH diet, which is dietary approach to stop hypertension. It is fresh fruits, fresh vegetables, and low salt diet, exercise, and all these things. If this measures is not drop the blood pressure, especially in stage 1 hypertension, then you can start treatment. But in stage 2 hypertension, you directly start treatment. Antihypertensive medication, angiotensin converting enzyme inhibitor, angiotensin receptor blocker, calcium channel blocker, diuretics, loop diuretics, thiazide diuretics, and potassium sparing diuretics, beta blocker, central alpha antagonist, clonidine and methyl dopa, and peripheral alpha antagonist, prazosin, and vasodilators. This is the medication with the dose and the maximum dose and the contraindication and the indication. So you should go through all this. Whenever you prescribe any treatment for the patient, you should go know the indications, the contraindication, and the side effect. But you should know that when you start angiotensin converting enzyme inhibitors or angiotensin receptor blocker, as Dr. Yasser said, you should follow the serum chemistry, the renal function test, and the potassium 2 weeks after. And it is contraindicated in patients with bilateral renal artery stenosis or renal artery stenosis in single kidney. Evaluation. So our evaluation will start from the history. As we know, the history is the cornerstone of any treatment in our patient. So history, then the physical examination. First, you want to know, is this patient hypertensive or not? So you need proper cuff size, repeated measurement. It will be 3 occasions, 3 occasions in different time. If you concern about white coat hypertension or mask hypertension, you should do ambulatory blood pressure measurement. Also, you should ask yourself about target organ damage to know it is urgency or emergency hypertension, because the management will be different, and you need to drop the blood pressure gently in the emergency hypertension. And you need to start intravenous infusion. Also, associated cardiovascular risk factor, diabetes, elevated lipid, and cardiac disease, and you know to search about the cause. Why we want to search about the cause? Because there is like a specific treatment for the cause. Then when you know the cause, you know the mechanism of hypertension, then you will choose the appropriate antihypertensive drug. Symptoms of hypertension, neurological signs and symptoms like headache, visual disturbance or vertigo. They can present with heart failure. They can present with subtle symptoms like tiredness, developmental delay, declining school performance, growth retardation, or epistaxis. Clinical history. So you should go to the history of secondary hypertension. You ask from the prenatal history, oligohydramnios, anoxia, umbilical artery catheterization, renal artery or vein thrombosis, or also you ask about underlying or concurrent disease like renal, urological disease, trauma, repeated UTI or recurrent UTI, edema, weight loss, failure to thrive, thirst, polyuria, nocturia, hematuria. Then also you ask about cardiac, endocrine, neurological, or cold extremities, intermittent claudication, palpitation, sweating, fever, and pallor, and flushing. And you also see the systemic disease like possibility of lupus erythematosus. You ask about any drugs. And as we said, history and or symptoms of target organ damage like headache, epistaxis, vertigo, visual impairment, facial palsy can be the presentation of high blood pressure. So any patient present with facial palsy, you should measure the blood pressure. Seizure, also any patient present with seizure, you should measure the blood pressure. Stroke, low school performance, dyspnea, chest pain, and palpitation, and syncope. Clues towards renal disease can be edema, polyuria, nocturia, hematuria, fatigue, muscle weakness, failure to thrive, history of oligohydramnios, and family history of renal disease. Also, renovascular disease, you should ask about, as I said, umbilical artery catheter, neonatal asphyxia, episode of severe hypotension, and tumor, you should ask about weight loss, flushing, and sweating. And don't forget the skin abnormalities in systemic lupus erythematosus, neurofibromatosis, and scleroderma, and family history such as hyperthyroidism. Also, the clues of essential hypertension, like the weight gain, diet, smoking in teenagers, and family history of cardiovascular disease, and sleep disturbance, like sleep apnea. Important question at follow-up visit, you should know about the medication side effects such as fatigue in the beta blocker, cough in angiotensin converting enzyme inhibitors, and neurosis in diuretics. Compliance, also you should ask about compliance with therapeutic lifestyle change, and compliance with medication. Examination, you should examine the patient from head to toe. you should examine the patient thoroughly. I will not go through all this, but don't forget the skin examination in hypertensive child. So we reach the clinical scenarios. We try to make it an interactive session. And okay, we go to, now we reach case 1. So 9-year-old girl was admitted to hospital with history of gross hematuria, edema, history of sore throat 2 weeks previously, generalized edema. He's not distressed, and the blood pressure is 160/120, other vitals normal, and no ascites. So anyone can be volunteer. You hear me? Okay. You can write your thought in the chat box.
Nisreen, we can hear you.
Okay. Okay, you can write yourself in chat box. Okay, so this is 9 years. The blood pressure is 160/120. So it is very high. It is more than 140/90. So it is stage 2 hypertension. So we need to define the high blood pressure. So he had stage 2 hypertension. Second things, we need to know if there is any signs or symptoms of target organ damage. There is no sign of symptoms of target organ damage. So this is hypertension because it is stage 2. This is hypertension urgency. It is not an emergency. Third things, we want to know that it is primary or secondary. So from the history, it looks like secondary because we have clues in the history and examination. So we have a child with gross hematuria, edema, and history of sore throat 2 weeks previously, and he's edematous. And we can ask about the urine amount. We can ask the mother about the urine amount. It will be oliguric. And then we can ask about detailed history about this gross hematuria. So what is your thought and how you manage this patient? Anyone want to volunteer? Okay, so this is stage 2 hypertension, hypertensive urgency, not emergency. So this hypertensive urgency, so we can start oral antihypertension because it is not hypertensive emergency. And at the same time, we can work up the patient. So we did the urine dipstick. The color is reddish. The blood is 4+. There is granular class 2+ with 3+ protein. We did the urine protein creatinine ratio. It is non-nephrotic brain proteinuria. SO titer is high. Anti-double-stranded DNA is negative. Serum creatinine is normal, and the urea is normal, and the electrolyte is normal. C3 is low, and C4 is normal, and ANA is negative. So what is your diagnosis? Okay, so this is acute post-streptococcal glomerulonephritis. Okay, how you manage the acute post-streptococcal glomerulonephritis? The acute post-streptococcal glomerulonephritis, the hypertension primarily is due to sodium retention. It is leading to fluid overload as evidenced by suppression of the renin-angiotensin-aldosterone system. There is no specific treatment for the disorder. Treatment is focused on relieving symptoms, and the major goal is to control edema and the blood pressure. And we need, during the acute phase of the disease, to restrict the salt and water. And if significant edema and hypertension develop, we administer loop diuretics. If the patient is still hypertensive and we need to add the second line choice is calcium channel blockers, and ACE inhibitors and ARB carry the risk of hyperkalemia and temporarily impair the recovery of kidney function. So it is not the good choice in patients with acute post-streptococcal glomerulonephritis. We move to case 2. In any case, we need to do the same thing, like define the hypertension. Then is it hypertension stage 1 or stage 2? Is urgency or emergency, and primary or secondary, and how you manage, what is your cell, and how you manage the patient. Case 2, it is 2 weeks old baby, term 38 weeks, day 1, post-omphalocele repair on IV fluid, not distress, well, no concern, and the blood pressure is 110/86. He covered with analgesia and antibiotics. So any volunteer or anyone want to write in the chat box? Okay, this the centile chart for the 38 weeks to 38 weeker. This is the post conceptual age 2 weeks. So you see here, the blood pressure is 99th percentile is 97/70, and our patient blood pressure is 110/86. So this is stage 2 hypertension. But the patient is asymptomatic, and the patient is well, not distressed. And he's day 1 post-omphalocele repair. So whenever they call me in the NICU, I should go and see the progressive blood pressure chart. When I see the progressive blood pressure chart, this patient is not hypertensive before, all the reading is well, and he is covered with good analgesia, he is not in pain. So our diagnosis is neonatal hypertension, closure of abdominal wall defect as one of the causes of neonatal hypertension. Just few words about neonatal hypertension and closure of abdominal wall defect. The mechanism in closure abdominal wall defect is compression of the renal parenchyma, vasculature, or pressure on splanchnic or pelvic nerve supply. We suggest thiazide diuretics and calcium channel blockers, and the renin-angiotensin-aldosterone system is crucial to the normal renal development pre- and postnatally, and ACE inhibitors may impair completion of normal development. So we should use ACE inhibitors and ACE inhibitors with caution in neonatal period because it's dropped the blood pressure significantly. This is one of the questions: which drug you should be used in neonate with great caution? It is the ACE inhibitor. This is causes of hypertension in neonate. Umbilical arch catheter associated with embolic or thrombotic events, congenital nephrotic syndrome, idiopathic arterial calcification, congenital rubella syndrome, bronchopulmonary dysplasia, pneumothorax, pain, and burst asphyxia, and adrenal hemorrhage. Also the ECMO and closure of abdominal wall defect. Patient in TBN can develop hypertension, and medication like vitamin D intoxication, theophylline and caffeine, and maternal drug use like cocaine and heroin. Case 3, this is a 12 years old child. This is 12 years old child present with 2-week history of headache, palpitation, diaphoresis, loss of weight, and the blood pressure 176/102, encephalopathic, and other examination is normal. What is your thought? Anyone can write in chat box. Okay, so this is stage 2 hypertension, as the blood pressure is more than 140/90. There is signs and symptoms of target organ damage. The patient had headache, encephalopathic. So this is hypertensive emergency. Okay. This hypertensive emergency. So in patient with hypertensive emergency, we should rush and admit the patient to the ICU or high dependency, and we should treat the blood pressure gently. And with this history, it is secondary because we have other symptoms towards the underlying diagnosis, like headache, palpitation, diaphoresis, and loss of weight. It could be pheochromocytoma. So hypertensive emergency is often seen in secondary form. Encephalopathy manifests with headache and change in mental state and seizure. Pathophysiology involves disruption of autoregulatory mechanism of cerebral blood flow, require immediate evaluation and intervention. So we admit the child to ICU, high care, blood pressure reduction should be slow in controlled manner, and we recommend intravenous infusion like labetalol because it will titrate the things and we drop the blood pressure gradually. This is algorithm of hypertension crisis, either hypertension emergency or urgency. Hypertension emergency, as we said, stage 2, we start with organ, we start IV infusion. The first step, in the first 6 hours, decrease the blood pressure only by 25% of the planned blood pressure. And the second step, we decrease the blood pressure gradually to the blood pressure around the 95 percentile in the next 24 to 48 hours. Then we add their oral drugs. And the third step, more than 48 hours, we decrease the blood pressure to less than the 95th percentile. In hypertensive urgency, if the patient tolerates oral medication, we start with oral. If not, we give IV infusion or boluses. Few words about pheochromocytoma. The mechanism of hypertension is catechol-induced. Although it is a rare cause of hypertension, has its unique set of management channels. Blood pressure needs to be stabilized until tumor can be surgically removed. Treat hypertension emergency with intravenous labetalol. It is well suited pheochromocytoma because it is alpha and beta blocker. An oral drug of choice after you wean the intravenous is alpha adrenergic blocker like prazosin. Workup, we need to work up the patient as our provisional diagnosis is pheochromocytoma. We need to measure the serum catecholamines, metabolites like metanephrine and norepinephrine, 24-hour urine collection of catecholamine, epinephrine, and norepinephrine. And we do CT is rather helpful than the MRI, is recommended for the first line imaging technique, and the MEBIG scan. And PET scanning has shown promising result as an imaging modality for pheochromocytoma. Case 4. We consulted by ENT surgeon regarding 7-year-old male admitted for tonsillectomy. Their concern, high blood pressure. The child is asymptomatic child with normal development. The blood pressure is 130/80 on 3 different occasions, all above the 99th percentile for age, sex, and height. And the body mass index is 31.8. He's obese and not dysmorphic and normal genitalia. Anyone can comment about the hypertension and stage and what is the cause? Okay, so this is a patient with stage 2 hypertension. Is asymptomatic, so it is hypertensive urgency, emergency, and there is nothing in the history towards diagnosis, but the child is obese, so it's going with essential hypertension. So it is type 2 hypertension, asymptomatic hypertension due to metabolic syndrome. Our workup will be the urine dipstick for protein, stress, urine protein creatinine ratio is non-nephrotic range proteinuria, fasting blood glucose is 6 millimole, and hemoglobin A1C is 5.9, pre-diabetic, and the total cholesterol is high, normal renal function test and electrolyte, and kidney ultrasound is normal. So this is patient with metabolic syndrome, but we will start treatment. We go like all the measures of conservative reduction of the weight and DASH diet, but we should start treatment because this is patient with stage 2 hypertension, as we said when to start treatment. This is the mechanism of hypertension in obesity. Due to obesity can cause hypertension due to hyperinsulinism, hyperlipidemia, because cause sympathetic nervous system activation, renal structural damage, sodium and fluid retention. Also, obesity can cause renin angiotensin system activation, affect the glomerular vasoconstriction, sodium and fluid retention, cause oxidative stress inflammation, cause vascular effect thrombosis, and endothelial dysfunction and vascular damage, which lead to hypertension. Case 5. This is 12 years old, previously referred by school doctor, neonatal period and painful, present with very high blood pressure. It is 194/116 millimeters. Our laboratory values include the body mass index is normal, hemoglobin A1C is normal, urea and creatinine is normal, bicarbonate is normal, and potassium and urine MS is normal. Echocardiography was done. It showed left ventricular hypertrophy with no evidence of coarctation of the aorta. So what is your thought? Anyone can write in the chat box. Yes, it is stage 2 hypertension. Yes, and it is hypertensive emergency because the child has left ventricular hypertrophy. We discuss how we manage the hypertensive emergency. And okay, so the KUB was done. It showed normal kidney shape, but the right kidney is 7 centimeters, which is small, and the left kidney is 9 centimeters. Other reports is normal. So what is your thought with this? You have a stage 2 hypertension. You have very high blood pressure. It is incidental findings, and with target organ damage, ventricular hypertrophy. And when you did the renal ultrasound, you found unequal kidney, and the right kidney is smaller than the left. Yes, yeah. So this renal artery stenosis. Okay, so what is your next step to confirm this is renal artery stenosis? Yes, we did the Doppler ultrasound. Blood tests that can be done. Blood tests that can be done and give you a clue for the renal artery stenosis. Yes, we did the serum renin activity and serum aldosterone activity for this patient, and we found both is high, the serum renin activity and serum aldosterone. So this hypertension is stage 2, renal vascular hypertension, and we did the Doppler ultrasound, DEMSA scan. Why we did the DEMSA scan? To assess the function of the kidney, and we did the CT angio. And it showed that there is stenosis of the right main artery and its branches. So factor indicating a strong suggestion of the renovascular hypertension, severe hypertension, more than the 99th percentile plus 5 compared with 8. Poorly controlled hypertension, you have a patient, you give 2 antihypertensive treatment or more, blood pressure is still not controlled. So think about renovascular hypertension, renal artery stenosis, secondary symptoms of high blood pressure like several symptoms, known or suspected previous vascular insult, patient with syndromes, they have high risk of vascular disease like neurofibromatosis, tuberous sclerosis, Williams syndrome, and sign of vasculitis. And don't forget the chiasm, previous trauma or radiation, and patient transplanted kidney, and bruit here over the renal arteries, or neonatal period, renal artery thrombosis or umbilical artery catheterization. And the laboratories that raise the concentration of that, it would be renal artery stenosis, raised peripheral plasma renin, and moderate hypokalemia and metabolic alkalosis, but will not present on all patients, sometimes will not present. This bilateral renal artery stenosis is more common than unilateral. Medical treatment is, in most cases, is not sufficient, and it needs surgical intervention, either angioplasty with or without a stent, or surgical treatment. And we should avoid the ACE inhibitor as when writing the chat box. Case 6, and this is the last case. So I want to see if anyone writes. Okay, you want to show the previous image, okay? Someone asked to show the previous image. This is the CT angio. It shows that there is, this is the arrow here. It shows there is stenosis of the right main renal artery. Okay. Okay, case 6, and this is the last case, 11 years old, presented with history of long-standing headache for 3 weeks, and he was previously well, and there is no family history of hypertension, kidney disease, or similar condition, and no history of using traditional medical or illicit drugs. Examination, patient, oriented Glasgow Coma Scale is 15 out of 15. Vital sign is normal, apart from the blood pressure, which is 211 over 147. It is consistent with stage 2 hypertension, with evidence of target organ damage. When we do the ophthalmological assessment, we find that he had stage 4 retinopathy. And this is stage 4 retinopathy for this patient. This actually it is not our. It's not for our patient. I took it from the textbook, but our patient has stage 4 hypertensive retinopathy. You saw that there is cotton wool and exudate and the edema of the optic nerve. Urine deep stick was done, and it showed proteinuria of 1 crust, no hematuria, normal pH, and normal specific gravity without other abnormality. We did the urine protein creatinine ratio. It is non-nephrotic range. Ultrasound of the abdomen showed that the kidney is normal in morphology, but it's a bit, the length is a bit high length. It is 12 centimeter, and the left is 14 centimeter. It is above the normal size limit for the age of the patient, and it is hyperechoic. Laboratory test was done. It is, we said that it is stage 2 hypertension, and it is hypertensive emergency. So you need to admit the patient to the ICU or high dependency, and you need to drop the blood pressure in controlled manner, and you need to start intravenous infusion. Then you, with the same time, you investigate the child to know the cause. So as we said, the blood pressure is more than the 95th percentile. The 95th percentile for the patient is 121 over 76. And with the new guideline, it is stage 2, 95th percentile plus 12. So it is stage 2 hypertension with normal serum sodium, with low potassium of 2.7, normal upper limit of serum chloride, and the urea and creatinine is normal, normal estimated GFR, and the serum bicarb level is high. So what is your thought about this patient? This patient has metabolic alkalosis, hypokalemic metabolic alkalosis with high blood pressure. What is your thought about this patient? Okay. Yeah, someone wrote tubulopathy. Someone, it is, yeah, it is. Someone wrote to Barter and Gittelman to differentiate between metabolic alkalosis and hypokalemic metabolic alkalosis. In Barter and Gittelman, they didn't present with high blood pressure. Okay, this is one of the things that you should put in Barter and Gittelman. They didn't present with high blood pressure.
Nisreen, some people are writing Lidl.
Yeah, I said that Lidl syndrome. Yeah, Lidl syndrome is one of the differential for this patient, and also the hyperaldosteronism. One wrote that hyperaldosteronism. So the differential between Lidl syndrome, it's right, hyperaldosteronism, either primary or secondary. Okay, so what is the workup that you need to do to differentiate? Yeah, we need to do the aldosterone level and renin level. Okay. Okay, we did the transtubular potassium gradient. The transtubular potassium gradient, it showed that you did the urine potassium, the serum potassium, the urine osmolarity, and the serum osmolarity, and you calculate the transtubular potassium gradient. And it was 5, which suggests that there is renal potassium wasting. TTKG in presence of hypokalemia, it should be less than 3. And in our patient, it was 5, so that suggests there is renal potassium wasting. So after that, we did the serum renin activity, which is low, normal value, it is low. And we did the aldosterone level, which is very low. And we did the serum cortisol level, which is normal. So this is going with what? What is your diagnosis now and how you confirm it? Anyone can write in the chat box. We did the aldosterone is level is normal, and the renin is low, also lower limit of normal. Yeah, it is Lidl syndrome. So how you confirm the Lidl syndrome? So it is hypertensive emergency and it is Lidl syndrome. We confirm Lidl syndrome by doing genetic tests for mutation of beta and gamma subunit of ENAC gene. And the unit and effective therapy, it is triamytrine and amiloride for hypertension. When you use this, the blood pressure will improve nicely. But unfortunately, really, we didn't have, because we just motivate for this treatment. Okay, this is this diagnostic algorithm for metabolic alkalosis. Some people, they said that Barter and Gittelman. So when you have patient with metabolic alkalosis, hypokalemic metabolic alkalosis, the first thing, you measure the blood pressure and you assess the hydration status. If the blood pressure is low or normal, you do the urinary chloride, and if it is more than 20, and or if it is less than 20. If it is more than 20, so there is chloride loss in the urine. So if the try to take patient active diuretics, Barter and Gittelman and hypomagnesemia. So it means that the patient with Barter and Gittelman, the blood pressure will not be high at all. It will be low or normal. And if the blood pressure is high, then at this time, the renin activity is low, renin and low aldosterone. So it is, you think about the aberrant mineralocorticoid excess like Cushing, licorice excess, and Lidl syndrome, and exogenous mineralocorticoids, and enzyme deficiencies. Secondary hyperaldosteronism, the aldosterone is high and the renin is high. Then you think about the malignant hypertension, renin-producing tumor, and renal artery stenosis. Low renin and high aldosterone, you think about primary hyperaldosteronism like Conn syndrome, bilateral adrenal hyperplasia, and carcinoma. So we reach the end of our cases. Home message that we took from this lecture: an appropriate cuff size is required for appropriate measurement of the blood pressure. Don't forget to measure forelimb blood pressure at the initial assessment. Appropriate therapeutic intervention are increasingly expected to prevent morbidity, and often identify etiology allow for therapy directed towards pathophysiological mechanisms. And when this is not possible, medication choice should be governed by maximum benefit and minimal side effect. And any patient with symptomatic stage 2 hypertension or blood pressure more than 30 millimeters higher than the 95th percentile should be treated urgently in the emergency department or high dependency area and inpatient setting. And children with hypertension and chronic kidney disease, proteinuria and diabetes mellitus, angiotensin converting enzyme inhibitors and angiotensin receptor blocker is recommended as initial medication unless they are contraindication. We reach the end of our session, and I hope it is useful.
Thank you,
Thank
Dr.
you.
Nisreen.
Thank you very much, Dr. Nisreen. Very illustrated